name of Jesus. Jesus' name we pray. Amen. So we're going to be starting right away. And my name is Adeleye Babarinsa. I'm privileged to be the president and co-founder of W.O.R.S.H.I.P Medical Missions. And our assignment today will be to facilitate this meeting, introduce speakers, and also share a few things about the title, the topic I have on is check the ICT and ICT and SDG 3. Before I start, I want to appreciate every one of us that are present today. I want to thank you for being punctual. I also want to appreciate our facilitators. Some of them are already around.
Yes, I know. I've already joined them.
There is no doubt that this meeting is going to be a very So I'll start by giving a brief history. W.O.R.S.H.I.P started in 2013 from the efforts of some core members who went to somewhere in the north.
Yeah?
And they were called by the need.
After I'm done with this
that was present there.
seminar.
They actively were involved in medical outreaches under the platform of the Nigerian Youth Corpers, Nigerian Christian Corpers Fellowship. And after their service, they eventually started W.O.R.S.H.I.P. That was me and my wife. And W.O.R.S.H.I.P was officially first announced on our wedding day. That was December 14. That was when we made a full commitment to start it officially. And it's going to be 10 years next year, and it's amazing what God has done for us. It's amazing that in the last 10 years, we have reached out to over 200 communities with impacts that are close to seeing over 200,000 people, and close to 1,000 surgeries have been done. And we've been to, as I said, over 200 communities, and the opportunities keeps increasing. If we were to respond to every invitation that we have, we will not have any free weekend. I mean, we're getting invitations from everywhere. And we thank God for how far God has helped us. How did we come across W.O.R.S.H.I.P's international platform? Because we realized that we needed people to understand what this vision was all about. It wasn't about individuals. It was about reaching out to people. And in 2017, in 2016, we had our first annual conference, and that conference was highly inspiring. The team was taking the nations, and it was from that conference we developed the vision for W.O.R.S.H.I.P's international platform, and we felt it was important we began to share our experiences with people and also provide a mentorship platform for young people that were interested in transforming their world. The theme for 2016 and 17, sorry, that was W.O.R.S.H.I.P International Platform 1.0, was raising world-class leaders, entrepreneurs, and professionals. And the reason why we came across that was because we felt that we impact the world. More than that, you could actually impact your world as a professional. Like many of us, you can actually be an entrepreneur and create solutions that may bring money into your pocket, but you're also impacting your world. And you can also just be a leader, whether in the political space, or in the civil space, or in non-profit, like what we're doing right now, and you are impacting your world. The second edition of W.O.R.S.H.I.P International Platform was in 2018, and the topic was achieving universal health coverage by 2030. So it was a time for us to ask ourselves, how feasible was it? Is it for us to achieve universal health coverage by 2030? And we shared a lot of light into what the universal health coverage means and what the SDG 2030 actually meant. And in 2019, the team was together to achieve sustainable health. we're looking at is the fact that one of the things that have slowed down the pace of achieving the SDG 3 was the fact that many of the health themes were not working together, especially in a country like Nigeria, which is our focus. I mean, there were incessant strikes among health workers. You know, once the ARD or NMA calls off their strike, then W.O.R.S.H.I.P starts theirs, and there was no way you could have a progressive health sector. And that was what we looked at. That is it possible for us to work together as a team? What are the factors that causes disharmony in the health sector? Then in 2020, the theme was high flyers. Okay, 3.0 was pace setters. In 2020, the theme was high flyers. And we're looking at leveraging on critical factors to create a healthier world. And that includes on young people, on community leaders, and on information technology, which interestingly is what we are focusing on today. The reason why we had to look at that topic was that as an organization, we realized that except we engage critical success factors, there is no way we are going to be able to make any difference, because we are dealing with an health sector that is very backwards. And these are the things that we have engaged in check. So you observe that in check, we pay attention to young people, because the truth is that most old people have enough problems on their own to begin to think about helping others. Young people are energetic, are innovative, are creative. And that's one of the things we've leveraged on in check. We talked about community leaders. For example, our last outreach to W.O.R.S.H.I.P, where we saw thousands of people, you know, it could not have been possible without leveraging on community leaders. It couldn't have been possible. So because we had the major community leader in Ogbomoso South that we're working with, he was able to connect with other lower level community leaders, and we're able to get to the community. And also with the leveraging of community leaders, we're able to access the politicians who naturally don't have listened to us. So we could draw the attention of the National Primary Healthcare Agency that gave us 2 healthcare centers free with donation of equipment from other healthcare centers. We could access the media, the major media station, the broadcasting cooperating organization of your state without paying any money. And we could access many facilities just because of we are going through the community leaders and of course ICT. Then last year, we talked about nation builders, because we realized that check was already playing a crucial role in building the nation. We got to a point where we could no longer be neglected. I mean, at that time last year, we had worked with several local governments, even in Lagos. I mean, we worked with the Badagry local government. We worked with the Etiosa local government, that's the Lekki in Lagos. I mean, when we're going there, they could not deny our offer because we had a track record. And we asked ourselves, what if check was going to play a crucial role in building, in transforming the health sector, not just within, I mean, what local government, not just in Ibadan, we've done several in Ibadan, in Lagos, and even also in Kogi State. I mean, local government gave us all the facilities when they heard that we're coming. So our focus was nation building. How can we actually be involved in actually building the nation? Remember, most of the things, successes we achieve, it's also going to go to credits of the local government, because local government is going to use our data. So when we say we do so number of surgeries and we saw number of people, the local government is going to also claim that this is part of the impact that they have made. And of course, why wouldn't they claim it? They give us the facilities, they give us the health centers, they give us some logistics. We have to work with the medical officer of health of local government. I mean, so we can't deny them from claiming it. But the question is, how can we be involved in nation building? And come to this year, the topic is, how can we accelerate universal health coverage via information and communication technology? This topic is so important to us, because as I speak to you, I'm speaking to you about 3 to 4 hours from civilization. So the next major, if I'm going to get to any major city right now, it's going to take me 3 to 4 hours. And the major cities that are close to me here right now are either I'm going to Ibadan or Ilorin or Gomosho. All those places will take me at least 4 hours. I mean, on the average estimate. So that tells you the kind of rural setting that I have right now. But thank God for internet. So because of internet, we can do a lot of things. We can do a lot of things. From here, we're providing support to those in Ibadan to facilitate outreaches. From here, we're actually interacting with those in Ogumosho to plan the last major outreach. That tells you the potential of information technology. And the amazing thing is that there are so many rural areas that a doctor may not get to, but those places have access to the internet. So we are asking ourselves, how can we learn? Because the truth is that Nigeria is highly underserved. I mean, we have limited health professionals, but the brain drain is happening so fast. And people are concerned that there will be a collapse. Rather than we focus on the problem, we are looking at possibilities of solutions. How can we leverage on ICT? You know, we had an outreach recently in Kogi State, and the woman that was facilitating the outreach was from Canada. But all along our conversation, I really thought she was from Nigeria, because she was, we were communicating and there was no issue with time zones. I just realized that she was more comfortable responding to my call, my messages at certain time zones. You know, I never knew. So we went to Kogi and I was looking for this woman and I was told she's in Canada. And I said, Jesus Christ. So she facilitated an outreach, linked us with local government, did everything, was talking as if we're close by. And she was speaking from Canada. I didn't hear any sound, any Canada sound. You know, for me to have thought she was speaking from Canada. That's the power of information technology. One of our facilitators today, Dr. Omotayo, you know, organized one of our biggest outreach in Ibadan. You know, and right from there, she was impacting lives here in Nigeria, right from the US. And before I introduce our guest speaker right now, I must also tell you that one of the things I will never forget him for was that we had a major surgical outreach. We had a major surgical outreach, you know, the Ibadan mega surgical outreach, and we wanted to take a lot of major cases, and we needed surgeons, you know, and, you know, I shared the vision with him. He was excited about it, you know, and he asked me that how many surgeons are you going to need? You know, because, I mean, my biggest burden at that time was how were we going to get surgeons for that outreach? We are told people to bring all kinds of cases that they had. How were we going to get surgeons for that outreach? You know, and he told me that, he said, Dr. Leye, how many surgeons will you need? You know, and I told him, and he kept getting surgeons and surgeons and surgeons. And you want to imagine the kind of surgical cases we did at that outreach. I mean, there was a case of someone that had a mass under the jaw here. And I mean, she had gone to UCH. Oh, well, interestingly, the guys that did it from UCH, you know, she had been going back and forth, back and forth. I remember when one of the surgeons saw it, he said, well, I don't think we should do this thing here. The other surgeon saw it and said, look, let's do this surgery. You know, and that's how, and I mean, when you see the lady today, she looks so beautiful. I mean, she showed me the picture, you know, some months later, and I was like, wow, it was a disfiguring mass. And after surgery, till date, everything, she looks so perfect. And there are many examples like that, you know, and that's amazing. This is someone in the UK making things happen in Nigeria, you know, by information technology, by connecting with those people, you know, and that tells you how much I really don't know how much we can do by information technology. And then this meeting is intentional because I hope to learn better. I have my pens, I have my writing materials here because I want to learn better. For those of us that follow us in church, we don't just have conferences like this, like what we have in Nigeria. We, after these conferences, we apply the things that we learn. And that's why if you look at our previous conferences, you would have seen the impact of those conferences in the way we operate the organization, especially for this third year. So let me just give you one or two hints because I don't want to take 1 minute out of our speaker's time. This year, we are being intentional about two things. We are launching Check International Surgical Outreach this year. So that means that we are hoping to do surgeries for at least 1,000 people, cutting across different ranges, dental surgeries like we have always done, oral maxillofacial surgeries, plastic surgeries, eye surgeries, and the like, gynecological surgeries. We are targeting 1,000 people from all over Nigeria and also outside Nigeria. The last outreach we had someone from a neighboring West African country. We had patients from all the states in southwestern Nigeria and a few states, in the Middle Belt. So that tells you, and many of these people were communicating to them through the internet. I mean, we made their diagnosis through the internet, we arranged their surgery through the internet, and they came and they had their surgeries done. And we're still following them up through ICT. So we're looking at Check International Surgical Outreach, and it's going to be mega. And we're still thinking about how we can leverage on ICT to actually impact a lot of lives. Permit me not to do much introduction. I have something written out here, but I don't want us to take too much time. Our guest today, I know he may not want me to blow too much of his trumpet, but we're not doing this because we want to, we are doing this just to help you to appreciate who we are inviting. Our guest today is a graduate of medicine and surgery from the University of Ibadan. He graduated as the best graduating student, and interestingly, despite the fact that he was also very committed in other areas. He was actively involved in FAMSA. He was the Bible study secretary of one of the major fellowships in the University of Ibadan. And despite that, and he was involved in several activities, despite that he came out as the best graduating student. He also did his residency in general surgery in the University of Ibadan, in the University College of Hospital, before proceeding to the UK, that's in general surgery, before proceeding to the UK to do further postgraduate programs. And it's someone that I respect so much. And one of the days we met together in one of the remote areas in Oyo State, like where I go, and it's someone that has worked in remote areas. So it's what he's talking about. And formal, I'm learning to be formal. With joy in our hearts, join me to welcome Dr. Adepoju. John, you have the floor, sir.
Thank you. Thank you very much, Dr. Leye. Can I confirm you can hear me clearly?
Yes, I can hear you clearly. Others can put yes if they can.
Excellent. I'm just going to share my screen. I may be looking away from the camera just intermittently. That's because I've got two screens. So just bear with me, okay? Excellent. And can you see my screen as well?
Yes, sir.
Okay, brilliant. Good morning, everybody. It is my absolute delight to be here with you this morning. My name is Olaleko John Adepoju. And thank you very much, Dr. Leye, for the introduction. I currently work in the United Kingdom. I'm speaking to you this morning from a small town in the north of Scotland. And I hope in the next 15, 20 minutes or so, we can have an engaging discussion and understand how we can accelerate the universal health coverage through ICT, and specifically speak about underserved communities and their surgical needs. I'm going to start by just having you look at this statement. 2 years ago, I was applying for a scholarship. I was applying for a scholarship, and then I was reading through the SDG report of 2020 by the United Nations. And this was the very alarming statement that starts one of the subsections of that report. And then it says, the world is falling short of its promise of universal health coverage by 2030. I mean, that's 9-10 years ahead of time, as at that time when it was published. And they already gave this very ominous warning that it looks like we may not even be able to meet the universal health coverage by 2030. And that's because of so many things that has happened in recent times. So of course, we know COVID has come with its own, and then it's actually slowed down so many things as well. But even before COVID, it was already looking apparent that universal health coverage may not be achieved if we don't do something and if we don't change so many strategies that we are employing to ensure that everybody is carried along. Now, we need to focus on low and middle income countries like ours, and more specifically, even in the middle of talking about low and middle income countries, we also need to focus on the underserved communities in those countries. Right in Nigeria, we know, many of us live in Ibadan and all of that. We probably think everybody has access to hospitals and all of that. I mean, if you've done NYSC, you will understand what I'm talking about, especially if you had the chance to serve in rural areas. I once worked in a hospital where I was the only medical doctor in a radius of about 35 kilometers. There was no other medical doctor in a radius of about 35 kilometers. And, I worked in a mission hospital. I lived in the hospital. And many times I will wake up in the middle of the night to do very, challenging surgeries, ruptured ectopic pregnancy, obstructed labor, and all sorts of things. And there are so many people like that who actually have no access to basic surgical care. And this is one of the things that led to this statement in the UNSDG report. And this is another thing said by Jim Kim, who was the president of the World Bank. And he made this statement about 8 years ago when they were commissioning the Lancet Commission Group on Global Surgery. This was a group of 25 commissioners, one of which was our very own Professor Emmanuel Ame, who is a pediatric surgeon in the National Hospital. So Jim Kim says surgery is an indivisible, indispensable part of healthcare. So the implication of that is whatever it is we do in all the outreaches and everything we're organizing, if we don't factor the aspect of surgical practice into it, we may be making a major error. Now, I'm going to ask you to have a quick look at this table. I know you have heard about so many malaria eradication programs, so many TB projects, about the Damien Foundation. You've heard about HIV/AIDS projects. I mean, I managed an HIV/AIDS project sponsored by USAID in Benue State in 2015, 2016, thereabouts. And, I can tell you for sure that lots of money are going into these projects. I mean, when you see people do outreaches and they're distributing insecticide-treated nets and all of that, lots and lots of money going to these projects. But the sad thing is that people don't really pay attention to the surgical conditions. And when we put surgical conditions together, that's quite a big bracket, the eye issues, the hernias, the gallbladders, the injuries, the obstetric fistulas, everything are all lumped into one. But what you can see from there is that surgical conditions actually bear a major disproportionate, burden of what the sort of things that cause deaths worldwide. Now, we look at a few peculiar challenges of low and middle income countries. We face all these sorts of burdens, but importantly, I need you to understand that in real time, in terms of absolute numbers, surgical diseases are just so many. And if you compare them to other things like malaria, TB, HIV/AIDS, and all of that, they are also disproportionately more. Unfortunately, we don't seem to pay so much attention to them. And the reasons for this are not far-fetched. I mean, if you look at organizing surgical outreach, if you ask the I was giving you an idea earlier, you need expertise, you need the surgeons, you need the anesthetists, you need the scrub nurses, you need pharmacists, you need theater practitioners, You probably need lab people, you need instruments, you need a suitable place to use as a theater. So you need all of these things. If you want to just, I remember when we were in primary school and they wanted to do the warming project, the warming program for us, they would just come with mebendazole tablets and line us up on the assembly ground and just give us water and ask us to swallow the tablets. And they would take pictures of us swallowing tablets and all of that. And they will go back to wherever they came from and put those things in their magazines and said, we conducted outreach and we dewormed 2,500 children. That already is an outreach for them as far as they're concerned. Tell me how much that will cost them. But deworm 2,500 children and perform surgeries for 5 people. Which one do you think costs more money? Which one do you think costs more manpower? So that is one of the reasons the surgical conditions tend to be neglected. I mean, I'm not saying those other conditions are not important, but there is so much that needs to be done concerning surgical conditions. I've talked about this already. This is one of the estimates. Up to 90% of people have no access to basic surgical care in underserved communities. That's really sad. If you grab that QR code, it takes you straight to the UN SDG report of 2020, and you can have a look at that. It may actually trigger your interest in getting more involved. And we know that there's this substantial increase because of the disproportionate attention surgery is getting, and of course, all the other things that are coming up, which some of my colleagues will talk about later. Now, this is the surgical referral system, all right? You can see the communities are there, and then the primary health setup, and then you have the disease palaces, according to Professor Asuzu. Now, the place where we need to focus is here, all right? And that is why, liaising directly with primary setups, going into the community to do outreaches, this is probably the best way to approach the surgical burden in underserved communities. Now, let's jump straight into how we can actually apply ICT in global surgery, because that's actually the meat of this session. Excuse me. Now, the one that is probably most obvious to everybody is telemedicine. Now, somebody's writing on my screen. So the one that is most obvious is telemedicine. Now, we've talked about teleconsultation. Before COVID hit, interestingly, I cannot remember ever doing any proper teleconsultation. I mean, you sort of speak to people on the phone, they say, oh, this is happening, what do you want me to do, and all of that. But proper teleconsultation, most people didn't do before COVID hit. And then as soon as COVID hit, we then realized we could do so much by just teleconsultation. So even in high-income countries, I mean, I've worked in the UK for well over 2 years, and I can tell you, I have run more clinics virtually than face-to-face. I mean, I think I've probably run 70% of my clinics virtually rather than face-to-face. Yesterday, I was seeing a gentleman with gallbladder polyps virtually, and it was all teleconsultation. You have all the information you need. They've done their test. You have everything on your screen, and you just do teleconsultation. And so there is nothing that says I cannot run a surgical outreach clinic with you right there in one village while I'm here in Scotland. We can pretty much do that. But how do we get that to work? There has to be good digital infrastructure in place. There has to be commitment from the government. If you're doing this in a public setting, there has to be stable power. There has to be stable internet access. I mean, you can't be looking at a hernia from here and you can't really see what the patient has because the internet is poor. That's going to make a mess of everything. And the other thing is that now these days we can do lots and lots of remote intraoperative support. I remember recently, just in my hospital here, I worked in a hospital where we didn't have vascular surgeons. And in the emergency room one day, a patient had femoral aneurysm and it ruptured right in our presence in Egypt. And what did we do? Of course, we had to rush the patient to theater, and we got a vascular surgeon who was 2-3 hours away on teleconferencing with us, and he guided us through the operation, and we completed the operation right there. without a vascular surgeon, just because we had a vascular surgeon teleconferencing with us. Now, this is what you can do. So if you even have to do that in a place like the United Kingdom, why can't we do that in Nigeria? But of course, you can't do that if you don't have the digital health solutions in place that you need to do these kind of things. So these are the challenges we may have, but these are things for us to think about. The other thing is we need to create a database. Most of the data I use for this presentation are from the Lancet Commission on Global Surgery. And I will link this to the next point I'm going to make so I can bite more time, which is research. So there is one statement that struck me in their report, the report of the working group of the Lancet Commission on Global Surgery. They said, through the development of this report, we identified substantial deficits in global surgery research, focus, practice, and capacity. There's no data out there. And trust me, the language of the funding industry is data. Now, thank God, check is going to be 10 next year. Do we have a solid registry of what we have been doing? I mean, we've done over 200 outreaches. We've probably seen, how many thousands of patients. Do we have a record of all these things? We've done so many operations. Do we have a detailed record of these patients? Do we have a record of their outcomes? Why not commission a group to write a scientific paper to celebrate our 10th anniversary, to say, in 10 years, this is what we have. And this is not just writing a report. No, that's not what I mean. What I mean is writing a scientific paper that will be published in a scientific journal to say the experience of a not-for-profit organization in low and middle income country, a 10-year experience, and just publish that and say, this is so much we can do without collecting $1 from without collecting one kobo from anybody, and put this data out there. I mean, I searched through, I did not see any not-for-profits publishing their data in a scientific paper. I mean, people publish reports, but reports from companies are not authoritative statements. You have to make it scientific. So data is what is going to drive what you can say. I mean, this kind of Lancet Commission can take that sort of data and say, we found an organization in Nigeria who have the data for what they have done in 10 years. And this is one thing we can use as pilot to see if we can actually leverage the effort of the third sector to actually go into achieving and accelerating universal health coverage in terms of surgery in the next couple of years before we get to 2030. So this is something for us to think about. Data, extremely important. And of course, the good thing about this is that we all don't have to be in the same place to contribute to this sort of work. There are different people in different places who can give ideas of how we can put this together and this can work. The next thing I'll just talk about is training and education. Thankfully, one of the panelists will be talking about this, so I won't take much time on this. But there is so much we can do. There are lots of people who want to know how to do some things, but they don't. There are people who struggle with how to do hernias and all of that. And I mean, some of us have done hernia operations in Nigeria, we're doing hernia operations in the UK, whether open or laparoscopic and all of that. We have a capacity to actually do a bit of training for people if the opportunity arises. But I know somebody will be talking more about education in terms of ICT, so I won't talk much about this at the moment. Now, there is a lot we can do with partnerships. I mean, Dr. Naya was talking about how we partnered with organizations, local government authorities, and all of that. I mean, I just thought about it the other day that, okay, what if you have a patient that has another massive gout and Dr. Limini wants to take it out? And, he's there wherever he's working as a consultant, and the patient is somewhere else. What if we have a collaboration with, say, Mikio or something like that in Ibadan, and they say, okay, as part of our corporate social responsibilities for this year, we'll give you 5 ultrasound scans, 2 CT scans, and 5 full panel of blood tests. You can send the patient. So if he does teleconferencing with the patient, you can say, okay, let's do this. Let's do the CT scan of the neck. Let's do this full blood panel, and let's do ultrasound guided FNAC. You send the patient to Mikio Health. You get all the results. You upload everything up to him. He sees everything. he plans the operation. He doesn't need to see the patient before the day of the operation. He just comes in on that morning of the outreach and he takes the gut out. So, I mean, there is so much we can do. There is a group of people from the UK who come to Nigeria to operate every year, and they haven't met all the patients before. Of course, they will need to examine a few of them, but they do all the consultations online, see all the results, and they just arrive, do all the operations, and within a few days, they've gone back. Now, this is another thing we can leverage. The same thing to sponsorship. People can sponsor right from New Zealand as far as that is. All they need is data, all they need is information. And this is one thing we can leverage in this regard as well. Preparedness is extremely important. We have a strong bond with the community in W.O.R.S.H.I.P. What if there is good communication pathway on ground, and then even when something else happens, maybe there is a hospital that's overwhelmed with surgical cases, and then they just get in touch with us, and the preparedness is there because there is that link of communication. We can do teleconsultation, and then we can advise on what to do right away. I mean, we're probably not ready for this. Telesurgery is a situation whereby somebody is actually operating directly by remote sensors, robotic setups, satellite connections, and all of that. Somebody is in the UK and is operating in Nigeria, operating live in Nigeria. But that's telesurgery. We're probably not there yet. But just put that in there just for us to be aware that these things are happening. I'm going to wrap up now. This should be my last slide. Now, I just put this there because, I mean, this is one of the things that struck me. Now, if you look at this, you can see, if you look at the bottom of this chart, you can see this. Now, this is cost effectiveness of surgery in low and middle income countries versus other public health interventions. So if you look at the most, the line at the bottom, you see that's malaria. That's how much you save, okay, when you do interventions for malaria and things, all the share insecticide treatment nets and all of that we tend to do, which is all fine. I'm not criticizing that, but I'm just putting this data out for you so you understand what we're doing. But when you come up, just look at the third row. You look at ophthalmic surgery. That's incredible. That is how much money you save when you take out people's cataracts, and all of that, which we are doing already. That's how much money you save. So that's how cost effective it can be when you do these operations. Look at general surgery. Massive impact, massive impact. So there is a lot we need to do when it comes to, surgery in underserved communities. There is a lot we can engage into information and communication technology to achieve in this instance. And there is no better time for us to actually do this than now. There is no better time because we are being stampeded towards 2030. We are not gaining much ground, and we know there is still so much we need to do. So we just need to think about these things and see which of them we can apply in our practice going forward. I am going to stop here. These are the references I've used. If anyone needs any of this information and you'd like me to send it across, I'm happy to do that. These are the references I've used, and I'm going to stop my screen share. And I'm not sure if we are taking questions at this moment or if we'll take them later. Thank you very much for your attention.
Wow.
I'll turn it over to Dr. Larry.
Wow, this was an awesome session. This was an awesome session, and we are very, very, very grateful. Honestly, I've learned a lot, and it's how I do for every year. Every year when we have worship like this, for me, it's always a learning opportunity. But I don't want to learn alone. I want our team. Most of the core members of our team are here. I want them to also learn, so that when I'm sharing certain things, we can all rub minds together. And I'm sure that you're going to be hearing a lot of feedback from us. You talked about scientific paper. One of the things we're doing this year is we're intentional about focusing more on doing the research on what we have done in the last 10 years. So we have been investing a lot of time in collating information, data, and all that. It's going to take us a lot. So we want to spend more time on reviewing that than doing outreaches. So we will not do many outreaches. we may focus on only few strategic outreaches so that we can have a lot of time to put our data in place. Not just because we want to get grants. Number one, for us to even appreciate the magnitude of what we have done, you know. Number two, for us to learn on how we can do things better, how we can make more impact in a more cost-effective way, you know, and a more scientifically accepted way, you know. But also in addition to that, we also will wish to get grant, and I think we should get it because I think there are a lot of good people that would love to support what we're doing. Because let me tell you one honest fact. One of the things that amazed me, and I'm going to try not to eat into the next person's time, but I think I need to emphasize this. One of the things that amazed me, for many years we had been working in Czech. I mean, we did a lot of things. So someone began to advise me that why not we improve on our media coverage? I never believed in that idea because in our first day in Czech, I met a media and ICT guy, and what he was telling me was, look, a lot of guys, you guys are doing it, they are doing stuff. So, you don't have to do much to get grants. He was showing me different sites he designed. Said these guys are not doing anything. They just gather pictures, you know. So I just got tuned off. In the first year of tech, I got tuned off in ICT branding, all those things, you know. But after third year, we had some struggles raising funds and all that. Someone told me, why not get a good media person, a good photographer, you know, to cover what you were doing? I mean, all these phone pictures will not pass any message. So we went for an outreach that I actually assisted. Because, I mean, it was quite tough starting. So it was one of a media guy went for his outreach and he took pictures of the outreach he went for. And I was like, wow, it was a village. But you see the huts in the village were looking so beautiful. You know, everything was looking so sharp. And it was like very happy. Yet it was a village. I wish I could share that picture. So one day I told the guy that if you don't mind, I would love you to come and cover our outreach. And I said, no problem. And we had no money to give him. Why? Because, I mean, in those days, we did outreaches for 20,000 because we're helping people with as little as 20,000 naira. We'll get some small drugs, you know, and so I will now pay 15,000 naira for a photographer. You know, and I'm still humanitarian, so it didn't make sense to me. But luckily, the guy said he was going to come and he won't collect any money. You know, and he came and he took the picture. He did interviews of people. I mean, that had brought their children with malaria. They said they were going to the hospital. They had, you know, and before you know it, people were saying from all over, where have you guys been? Wow, you guys are doing amazing job. And I was like, we've always been doing jobs. You know, and I was just telling you what the difference that just having a good media. And today we invest in all the media. Our last outreach, we spent at least $500,000 on media alone. For me, that would, my normal person, that's crazy. But of course, I understood that, yeah, I mean, $500,000. I mean, but the truth is, $500,000 also, we spent lots more. I mean, several millions on that outreach. But the truth is that if you had not been keeping these things, we probably would have lost memories, you know. And so I don't want to say more than that, but I'm just also telling you also that we're intentional about these scientific papers, and we are hoping that you also assist us. So we're going to get back to you, especially in the areas of surgeries, you know, because presentation matters a lot, you know. So but we'll collect information and would require for help when due. Before we take questions, because we're already eating the next time, I want us to take a group picture with Dr. Olajon. And if you don't mind, I want all of us to switch on our videos if you can. And I think you should. I know there's a lot of financial constraints in this current economy. Okay, so I want all of us to switch on our videos, except those of you that are really, really hard with data. Please, admin, help us to switch on our videos, please. Allow us to switch on our videos, please, so that we can take a picture. Thank you. Admin, can you help us with that, please? Okay, so while the admin is helping us with that, I don't know if there's anyone that asks question. You may only take one or two questions. Can you just, if you have a question, can you just wave if you have a question? Or you type your question, please. Can you if you have a question, can you wave or type your question? If you don't have, it's okay. If you want to ask later, it's okay. But if you have a question you want us to answer. Oh, the admin, you're not helping us with the video. Okay. If you get so if you have a question, can you just type it? Okay, so we can on our videos. Okay, so in the absence of question,
I have a question.
one other thing, why the admin is taking the video. So admin, please take the video, please. Oh, my own video. Why is my video not? Admin, you have disabled my video. Okay. Okay.
Like, I have a question.
While we're getting to our next speaker, I also want to mention one thing that is a big challenge. Oh, can see my son. Delight, come and show in our video. Is one of the major challenges in this part of the world is actually government bill.
Yes.
You may not know some of the things we circumvent, and I don't want to say much. I was listening to Shiloh yesterday, and someone said you don't speak against your employer. So I'm currently employed by the government. I can only talk about the great things that the government is doing. But if you know but the things I know are very shocking. Yeah, and they are such that I will not encourage any young person to work within this country, except you have a strong will. I mean, I've led the primary healthcare center run by the government. I can tell you a lot of wonderful things that are on ground on paper to make sure that things are working very well. I've also headed a general hospital. Okay, I think Dr. Lajan will know a little bit about my experience because so today, and all because I just wanted to do things the way it should be done. I'm not doing anything special. So I'm just doing things the way it should be done. And currently I work with the state specialist hospital. I'm at higher level. You understand? So I don't want to go into that. So, but so it's not, many of the things are not as easy as it goes. One of the ways we navigate the government is by building a relationship with good people in the government. Because let me tell you, there are good people in the government, just like I'm in the government now. And no matter what you say about the government, there are good people there. I'm not a bad person, no matter what you hear. But we have to navigate a lot of things. So, but we are going to keep navigating it. And I believe that with the help of God, we'll get there. So I've said a lot in that statement, about some of the challenges that we've had to deal with, even with tech. So please, are we done with the pictures?
Sir, I have a question, sir.
Please go ahead with your question.
Okay, so from the presentation from the doctor, I want to ask, I'm a medical laboratory scientist. What is the role of medical laboratory scientists in all, because all what he was measuring was surgery, things that to do with doctors. So how do we come into place? Because I didn't really hear anything like that relating to lab scientists, something like that. So that's my question.
Well, that's an excellent question. That's the only question we're going to take because of time. Our next speaker is set already. But it's important you know that Dr. Lajan, I'm sure you're aware of this, in Czech, we're intentional about having professionals from across board. So in Czech, we have professionals, both professionals and students, because of course we started majorly with students, but now we have professionals from medicine to dentistry to pharmacy to medical lab science to nutritionists to imaging scientists, physiotherapy, and all. But so we have different spectrum of people represented here, and I'm sure you're aware of that. But of course, I want you to just answer that question. I'm sure you didn't do that. You didn't omit that deliberately. You understand? We're just speaking generally, but I guess because we're focusing on surgery, and surgery probably has to do majorly with the doctors. I guess that's what happened. Yeah. So please go ahead to respond to that question. Dr.
I think you've answered. You've probably given half of the answers. This section, this part of the presentation just focuses on the surgical needs. There is also one of the panelists who will be talking about non-communicable diseases, infectious diseases, and someone else will be talking about another aspect. So I imagine you will find where you fit in each of these different segments of the presentation. Now, in terms of surgery, like I was saying the other time, if we want to do major operations, we will probably need people to have blood workup. They will probably need blood transfusion facilities and all of that. You come in everything like that. When we go to the field to do all sorts of tests, we do malaria tests and a lot of other complex tests as well. Those are the places where you can take the lead in getting involved in all of those things. I've just only limited discussion from my side to the surgical needs, but I'm sure at the end of the presentation, I think the last part of the presentation talks about how you can find your niche in Czech as an individual, whatever it is that your line of specialization is. So you will get more insight into that as the presentations go along. Hopefully that answers your question.
Well, thank you very much, sir. We're very grateful. I'm happy that you are not just a guest. You're actually fully part of us. So, and everybody here is fully part of us. So I may not be too carried away with protocols, you know. So we are very grateful. I will pray. Yeah, I just thought about someone you were. There's a guy in Modoya that they supply blood transfusion products through ICT. Some stuff like that's where one of the lab comes in. So we'll still talk about. So thank you very much, sir. And without much ado, we welcome our next speaker, Dr. Omotayo Temitokwe from the United States of America. She's a public health expert, and she's going to be speaking with us on the role of telemedicine. And she has been very impactful in Czech. I mean, led the Czech diaspora team, and currently also heading the Czech United States of America. We're trusting God to build our diaspora chapters more, and we know that the Lord will help us. So without any much ado, we'll welcome Dr. Temitope Omotayo Ni Grillo. That's the daughter of the popular Professor Grillo. Thank you very much. Please, we're adding 10 to 15 minutes to your time because we took some of your time. So please go ahead. Yeah.
Good morning, everyone, and maybe perhaps good afternoon. Please, can you all hear me clearly?
Yes, we can.
Okay, because
We can hear you.
I'm trying not to be too loud so that I don't wake up people in the house. First, I would say it's a great pleasure to have this platform, this opportunity. I want to thank the leadership of Czech, for the honor. Without taking much of our time, I'm going to dive straight to the topic, and I'm going to be looking at a different screen here. And then, if it's okay, I'm going to share my screen. But in case you just see my attention is going on, so I have a second screen here. So. Share my screen.
I know what's going on. Not Max. Don't have to. Okay, is this Anthony that is sharing the screen?
Am I allowed to share my screen, host?
Yes, you can. You can share your screen. Admin, I hope that's sorted out. I think you can share your screen.
Can you all see my screen?
Not yet. Not yet. Please, admin, can you help us with sorting out the screen? Admin, please, can you help us with the screen, please? Are you having challenges sharing your screen?
Yes.
Okay, yes, it's sharing now. We can see it now. Yes, it's sharing. We can see the beautiful twin. Yeah. Yeah.
All right. So basically, when we talk about telemedicine, just like the first speaker spoke, we're dealing with using telecommunication or information and communication technology controls. But it also goes beyond coding. Saying we can also even use it for I mean, very in advanced countries now, they are thinking of doing even robotic surgery, but you can use it for things like, investigation report. Like, and when I talk about investigation, I mean like ordering tests and getting the report back to the doctor who ordered it so that they can see the result and give feedback. We can use it even beyond doctors and surgeons alone. Other allied health workers can now use, telemedicine, physiotherapists, optometrists. You might wonder how is this possible? Yes, but yes, it is very possible with the current technological age that we are in now. Uh, so what is telemedicine? According to a writer, Efferson, he described it as a form of medical clinical activity that relies on telecommunicated information exchange for consultation, medical diagnosis, and patient care. That's why I said, it goes even beyond consultation. You use it to make diagnosis, use it for overview of, patient care generally. And that's why I mentioned other allied workers now being able to even use telemedicine. And the whole essence, what makes telemedicine different from the regular, form or conventional one that we're used to is that there is no in-person, uh, that in-person link is broken. You don't get to be in the same room with the doctor or the healthcare provider. You can be, thousands of miles away, thousands of kilometers away from where your doctor is, and you get to, you know, be treated by your doctor. And now when we talk about, I know some the Sustainable Development Goal 3, what it majorly talks about is to ensure healthy lives and promote well-being for all at all ages. And now there are two of the targets there that the topic I've been doing talk about addressing. Target 3.3 of the SDG 3 goals is that by 2030 to end epidemics of AIDS, tuberculosis, malaria, and neglected tropical diseases, and to combat hepatitis, waterborne diseases, and other communicable diseases. So this speaks about common infectious diseases that have been plaguing especially low and middle income countries. And we see here in the diagram, we can see the numbers, the children that are affected. Even vaccine preventable diseases are still knocking down young children under 5 children in low and middle income countries. We still have epidemics of tuberculosis in some regions of the world. And then for the target 3.4, this talks about non-communicable diseases, and the target is to reduce by 2030 to reduce it by one third premature mortality from non-communicable diseases through the prevention and treatment and the promotion of mental health and well-being. Now, one thing that I like about this goal is that it's kind of holistic when it comes. This target is now kind of holistic. It addresses even mental well-being. And now we're talking about how telemedicine can do this. It 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 sure can. Telemedicine can help achieve these goals faster than we can even imagine compared to the age whereby telemedicine had not been something that was in vogue. Prior to COVID-19, usage of telemedicine, even here in the United States, was pretty low. But that's one of the things, such an oxymoron to say that COVID-19 brought, the advent of telemedicine, and especially even though initially here in the US, telemedicine was something that was more prevalent for access of care in rural medicine. But when COVID started, we were even using it even in urban areas. And then this here, the insurance, medical insurance is something that is, kind of a priority. There was a time whereby the government would even find you if uh, you're supposed to have medical insurance and you don't have it, they will find you. That's how much priority that they place on medical insurance. And now, at the time of COVID, most of the insurance companies were not offering coverages for teleconsultation or any form of care received via telemedicine. But with the onset of COVID and a lot of practices had to switch to telemedicine. Even insurances started to cover telemedicine just because they were able to harness the opportunities and maximize telemedicine. Now, telemedicine can, facilitate a broad range of interactions using different devices. And the good thing is that even your phone, as small as it is, can be what will provide healthcare to you. And you don't necessarily have to have a big, back in the days of when telemedicine was started, you probably would need, all these sophisticated equipment or a big computer. Usually, most times we were using computers because we believe that the software could only work on computers. But now they've done a lot of software, a lot of apps that you can just have on your phone. I remember sometimes earlier this year, I needed to one of my babies needed to see the doctor, but I had to do it via telemedicine. They just gave me that opportunity. They said you can do this telemedicine, even though the clinic I was supposed to take him to was close by. But the moment I saw that option, oh my goodness, I just embraced that option. And believe me, I did the consult for my child right on my phone. I didn't even have to connect to my computer or tablet. I just used my phone. I use the camera on my phone to show the doctor, the area that the doctor needed to see visually, and then we wrap it up, and the doctor provided service to my child. I didn't step out of the house. I didn't have to take him anywhere, and that was it. So that's how much benefit that telemedicine now offers. Phones, tablets, and here they also have some monitors that they use, especially cardiologists. They use a lot of telemetry monitors for their cardiac patients. They can just have the sometimes they don't even have the patient come to the office to get it fitted on. They will just ship it to the patient's home. The instructions are there, and they use all these to monitor cardiac reading, patients who are prone to having arrhythmias, that abnormal rhythm at any point in time, and could have sudden cardiac arrest. They use all these devices to avert that. So that is how much that telemedicine has really been able to offer in this present ICT age. So I was saying that COVID-19 brought a lot. It opened the eye so much when it comes to the prospect that telemedicine could offer here in the United States. And you might wonder, why am I even in the United States? Well, sorry, I've lived there for a while now, so much adapted here. But the good thing is that there are some things that, not even some, lots of things, even that they do here in the US or in the UK, that we can even adapt to uh, uh, to Nigeria. Well, fine, we know that we need a lot of government support, and it is so sad that when the government support is lacking, some of these things are slow down. Well, and especially I'll emphasize more on that when I talk about barriers of telecommunication, why this is might not be most smoothly, especially in a country like Nigeria. So, but back to the scenarios whereby we can use telemedicine. Here in the time of COVID, they would use it to triage whether a patient having symptoms, respiratory symptoms, needed to go to the hospital or just stay back and get some prescription sent to their pharmacy and get themselves treated. They could also use it during the time of COVID. They were using telemedicine a lot to for maintenance of care of uh, chronic non-communicable diseases such as hypertension, diabetes, lipid disorders, patients that were on this long-term medication for certain chronic conditions. They did not necessarily have to go in to be seen by their provider. They just have this teleconsultation. The doctor would, through the use of mobile apps, they would send in, or even emails, they will send in some health questionnaires for them to fill ahead of time. And the doctor will look through it before, having to have the steady consult with the patient. The doctor looks at it, to know what line of care is going to follow for this patient. And then the patient is connected to the doctor, even if there needs to be some tests done, laboratory investigations done. Here they do something by the law, whereby they just say, go do this test at the location close to the patient's address. So all they just need to do is, because of the way telemedicine has really evolved in this country, and also electronic, health information has really evolved in this country, they are able to do everything electronically. They just send in the laboratory investigation to maybe the lab that the patient chooses. They send in the orders ahead before the patient even goes there to that lab, and then the patient can call the lab, book an appointment, go do their investigation. When the result is done, the lab will just send the result not to the patient, but they will send it back to the doctor. Of course, the patient can always request for their result. Here most times they will ask you to request for the result from your healthcare provider, the doctor. So the patient can request for the result from the practice. For that, and that's even to answer the question that came from the last speaker's session about how medical lab scientists can be involved in telemedicine. That is basically here, that's what they do now. The doctor will just send the order to the lab that is closest to the patient's house. The patient will call that lab, make an appointment. They will go there, do their test. The lab will send the result electronically back to the doctor. And then the patient will have another telemedicine appointment with the doctor, whereby the doctor will then talk about the result, basically giving feedback. This is a screenshot of a company that used telemedicine to address their cardiac patients in very remote areas. This practice here, they've been having issues with their patients that were in remote areas. Whenever those patients had maybe some cardiac events, like cardiac arrest, or they had like congestive heart failure that would lead to sudden emergency issues, and they went to the hospital and they were admitted. Now, whenever this patient had to go back to their location, after discharge, most of these patients were living in rural areas, and continuity of care became an issue because most of these patients were reluctant to go back to the hospital that is located in the city where they were treated for follow-up. But one way that this company was able to, this healthcare provider was able to address this issue was using telecardiology. And basically what they did is that they created, centers in that rural community whereby there were standby, like maybe nurses, receptionists, front desk workers, but the doctors who were not there in person in those rural communities, they are seeing the patient via telemedicine. They have this room, they have rooms already whereby the doctor will consult with the patient using audiovisual gadgets. So here, telemedicine, you can use it to conduct maintenance of care, like I earlier said. You can use it to triage infectious diseases to determine, okay, which one is severe enough that this patient has to go into the hospital to be admitted or to be seen. You can use it to request for investigations and receive feedback. Now, and the benefit of telemedicine here is that it will increase access to care for remote patients, especially in a country, Nigeria. I remember when we went to Igora for our community posting. Very beautiful, town. Quite big, for that level of in terms of size of community, but quite big. And they only have this health center besides Adejobi's hospital at Oruwa. We only have this, primary health center whereby the medical students went to do our posting. We just most times there was only one doctor that was sent there for youth service posting that was on ground. We did have another supervising consultant, but he would go to the city every now and then. So, but a place like Bora can benefit from telemedicine in the sense that they can even have multiple specialists seeing patients. They're not just primary, the primary doctor would see all cases. And when it comes to, referring, they had to refer them to that's Professor Adejobi's clinic. But they can have a case whereby even cardiologists, pulmonologists, surgeons can see their patient at that primary health center to provide health care. And this would increase access to care. Also, it helps deliver prompt care, because they are eliminating that gap of having to travel, commute over certain distance. They are eliminating that people can get care early enough before things deteriorate. A lot of times in Nigeria, so many people, something that would start, a health condition that would start small would grow, it will become something big just because we delayed seeking care. And telemedicine would help to eliminate such, because people can get care early enough since that barrier of traveling, commuting has been removed. Also, it can help to provide continuity of care, just like I gave in that scenario of that, healthcare system here, that healthcare provider here that realized one of the barriers of their patient receiving good care was continuity of care. Telemedicine can ensure that there's continuous care because they don't have to travel back to the hospital where they are treated. They can just be seen at their remote place or via telemedicine. And also, it can help reduce the cost of care because, of course, you remove cost of transportation. Also, you would eliminate certain costs. Perhaps if you went to the clinic, you would first be seen by the receptionist, and then you'll be seen by a nurse before the doctor will then come and see you. But with telemedicine, if you are being seen just in your comfort of your room, it's just going to be you directly to the doctor. Fine, there might be some charges going to maybe the software that they use that they have to continue to maintain and things like that. But it will not be as much as if they had to pay other workers that are there in the hospital. So this, overall will reduce the cost of care. So it's cheaper compared to conventional care. And some of the barriers that we might then have, like I said, I'm going to talk about in Nigeria. We have the issue of poor and inadequate telecommunication network, either in terms of cost. People might not be able to afford data on their phones, or they might not be able to afford even calling card to be able to speak to the doctor because of the cost. Also, the strength of the network. I know that where Nigeria started in terms of telecommunications is, thank God they really moved ahead to providing. I know MTN says everywhere you go, just because they're trying to tell us that they have their networks all over the country. They try to penetrate even rural areas. But we know even here in the US, we still have that issue. Some rural areas still have barriers in terms of lack of good network or strong network. Also in Nigeria, electricity is going to be like one of the major barriers. If you talk about using telemedicine to increase care in rural areas, then these rural areas are the ones whereby for several months they won't even see sign of electricity. I mean, that's going to be difficult. That's really going to be tough. Also, the literacy rate. Some people, especially older generation, they might not know how to really operate the devices that will bring this telemedicine to them. They might need the help of their, offspring who perhaps would have left the villages to the cities, and that might become a challenge. And then cultural beliefs. Some of especially older people that believe that the care that they would receive over the phone is not as policy, not as good as if they went to the hospital to actually see the doctor face to face, and the doctor is able to examine and able to say, that they usually see them, you can for sure say, oh, this is what you want, this is what you need, and things like that. That could also bring a form of barrier to the use of telemedicine in a country like Nigeria. the most important thing to take away, I would say, is this: achieving the SDGs has now been made possible in this present technological age. In the past, whenever we study the SDGs, we would see that even as the years we are drawing by, these things are not being achieved. The indicators were still low, and we could see that, man, it looks like as if achieving these goals would take several years, even beyond the goal that is set. But thanks to things like telemedicine, things like ICT, achieving those goals are now possible more than before, like just more than you can even imagine. You can imagine, in as much as people, especially government, they are willing, and then the people are also willing, so this SDGs can be achieved in low and middle income countries. Thank you very much.
Wow, thank you so much for the presentation. That was such an awesome one. For me, there's a lot of take-homes from that presentation. She just shed more light. And thank you also for the slide, because I believe we're going to share the slides to everyone that was part of this. We'll share the slide with you because we're going to, there's a lot of enlightenment on how we can engage telemedicine. And she also looked into the barriers. And believe me, the barriers are so much in this part of the world. The question of literacy, the question of cultural beliefs, the question also of poverty, and all that. But, we believe that we're going to navigate these barriers, and we know that God is going to help us. We're just going to take just one question. We need to take the next speaker now. This session closes by 9 a.m. I mean, we bought the time for 9 a.m. So can we just take one question from anybody? And other questions can go to her WhatsApp, or if questions are coming fast. Questions. Yeah, someone has a question. Please just go ahead if you have a question, or you can type. Okay. Okay, so it is okay. So okay, so in the absence of question, maybe I should just ask the question, Dr. Motayo. I'm just wondering, looking at the Nigerian setting.
I'm just following once in a while, not 100%.
Setting, and all that. How realistic? Because I'm still doing my research. How realistic do you think we can engage in telemedicine? Because I'm looking at some of our outreaches and all that. How realistic do you think telemedicine is in Nigerian setting? Maybe I should be more practical now. We're looking at poverty here. We're looking at network challenges. We're looking at most doctors might not want to engage in it, since most people that will need are poor people, if you are not going to be paid for it. I'm just looking at many of these challenges we have. Have you ever thought about it? Do you know of any organization that is actually really engaging in telemedicine in Nigeria? I've been thinking about it. I've looked at people involved. Most of those I know started probably have stopped or something. How much, because I'm thinking about something like that, but because sometimes I would rather even advise people on phone than recommend drugs to them, because most people are just looking at it as a shortcut. I want to ask, have you had any experience with any organization? Maybe that's what I want to ask. Any organization that is actually successfully engaging telemedicine in Nigeria? And what are the things you have thought about with your experience on how we can even make it more realistic? Reaching out to people, especially people that cannot access. Yeah. I don't know if my question is clear, but
yeah, that's a very good question. I'm not really sure of organizations. I think the best that really comes to my mind readily is, I believe that there are now some apps even in Nigeria that mobile apps that have been created for people to be able to converse with doctors in Nigeria, mobile apps. And that's for people who are able to navigate, apps on their phone. Especially the younger generation and even older folks who are technologically savvy. I know I might not be able to think of one particular in terms of name, but I know that there are a few mobile apps now in Nigeria that people use for teleconsultation. Funny enough, there was a time I actually even thought about creating one myself as a startup for teleconsultation in Nigeria. But then when we talk about mobile apps, we might still say, oh, this is actually providing healthcare to those in the cities and urban regions. How about those in the villages? Well, there are practical ways that one can come up with to actually solve this issue, especially for those in the rural areas. I think of it as a situation whereby you can have a health center, you know, but rather than having, in a case whereby you have to send patients to general, regional, tertiary hospitals and say, oh, you don't have the specialist on ground that can see you, that can take care of you, or we have a case whereby a patient who has diabetes is now having serious complications because of their poor management of their diabetes, poor management of care, and then they need to go see other specialists such as um, orthopedics. That's going to be very extended by the patient. Or maybe they need to see actually an endocrinologist now, not just a primary doctor. And then they don't even have access to go to the endocrinologist because there is no endocrinologist in that rural area. In that health center, you can just have, the government can provide computers and set up like a telemedicine station in that primary health center, whereby the patient, the primary doctor will then, receive consultation from this specialist. Dr. Olajon spoke about teleconferencing with a vascular surgeon when we had a case of, ruptured femoral aneurysm. So something similar like that, we can build such a thing in rural health centers, whereby patients in the rural health center, they don't need to travel kilometers to the city to go see specialists to receive further care. They can build it. And why I'm saying they can have that rural center is because I believe that because of literacy rates, they might not be able to perform this telemedicine, set it up or access it on their phones. They might not even have smartphones. Some might not even have phones at all. But if the health center, primary health centers in the villages can set up a telemedicine. Please give me 1 second. One of my babies are here.
Okay, so thank you very much. We have to stop there. The next speaker is ready. Thank you, Dr. Omotayo. She has beautiful twins, wonderful twins, and we're very, very grateful. We'll be coming up right now. Busayo, all the way from Australia. She did a residency in pediatrics while in Nigeria before she moved down to Australia. And so, hope you don't mind, Dr. Omotayo, we have to move to the next speaker because of time. We are very grateful, Dr. Grillo.
Yes, please. Basically, I finished. I had to rush off because, I didn't want her to wake up the second child.
Yeah, I understand that very well. So, and Dr. Owoye, please, you can take over, please. Thank you very much. We don't want to take much. You're welcome, please. She's in Australia as a resident medical officer. I can't remember the hospital right now. I don't want to take time to read the profile because of our time. Go ahead, please, Ma. Dr. Owoye Busayo, please. Wow. I will check it out. Okay, so so while we're waiting for her, let me just continue. Hello, Yeah, you have to come up now. Just speak. Yes, I've introduced you. So just speak already. Okay. Yes, I can see you. We can see you. Wow, she's not.
Hello, can everyone see me?
Yes, we can see you. Yes. How's Australia? Hope it's awesome.
Can you hear me now?
Yes, we can. Yes.
Can hear you.
Yes.
Okay.
Yes.
Okay. Can everyone hear me?
Yes, we can.
Okay, well, that's really good. So, thanks to the organizers for inviting me. My name is Busayo Weye. I will be taking how high city can help to reduce maternal and child mortality in Nigeria. So we'll be talking about practical ways it can help to reduce maternal and child mortality. Unfortunately, maternal mortality is still quite high in our country. It's still extremely high, much higher than one would actually imagine. Or from research, we could say like 40,000 pregnancy-related deaths occurring in Nigeria up to now, and this accounts for about 14% of the global total, making it like top 10 making Nigeria one of the top 10 most dangerous countries in the world for a woman to give birth. So a lot has to be done to reduce the mortality rates among mothers, because giving birth should be a thing of joy for every family, and as much as possible, health workers should endeavor to make it successful. We don't want situations whereby women want to bring new ones to life and they are dying in the process. Child mortality rate is also extremely high. As at 2020, Nigeria still had 113 deaths per 1,000 live births. That is unbelievable. It is just too high. We can't compare what we have in Nigeria with what nations that have good healthcare systems have. So these are things we really have to work on. And I think information and communication technology can help us to reduce these rates because it is easily accessible. Information and communication technology involves the use of mobile phones, not just telehealth, because as at today, telemedicine in Nigeria is not booming as such. It's one of the things that we will use to curtail mortality in future. But if we will be realistic, I think our focus should be more on using mobile technologies to reduce mortality. And some countries have been able to achieve this. Like in Malawi, they organized W.O.R.S.H.I.P. And this health system helps to develop applications that people can download on their mobile phones. And through these applications, maternal health information are made available and accessible to pregnant women living in hard-to-reach communities. And average Nigerian will still be able to afford a mobile phone. And most people now use smartphones, even market women. And by providing these applications in in easy to use mode and also in community friendly mode. We build applications whereby people can access information in their own mother language. It can help to reduce maternal mortality because most of the causes of maternal mortality in Africa are preventable. Things like hemorrhage, infection, things that can be easily prevented are things causing death in mothers. So if applications are provided and people can access them in their own languages and they know what to do to prevent such situations, it helps. For instance, now a woman who is pregnant who develops edema and talks to her neighbor, the neighbor may just say, oh, I've experienced it. It's what every mother experiences. And you know the way Nigeria is, everybody talks to someone. And everyone in Nigeria knows even more than the doctor, at least within themselves. So a pregnant woman talks to a woman, she gives her wrong information instead of presenting to the hospital. But a woman who has access to this application can put in information into the app, and it may say, oh, this may be a sign of eclampsia, it may be a sign of something bad about to happen. That can prompt them to present to healthcare center and things can be done. So these will help to save lives. Other ways of using ICT to prevent mortality may be sending SMS messages to pregnant women. You know, SMS messages that gives them information on what to expect at each stage of pregnancy. Oh, during first trimester, this is what you expect. During second trimester, your child should begin to kick. You should begin to feel fetal kicks. And if you don't feel it within certain minutes, present to the hospital. When a woman knows that, oh, she should feel fetal kicks within certain minutes, at least she knows the minimum number of fetal kicks she should feel in a day. If she's not feeling it, she can present to the hospital because most people are responsible, but a lot of people lack knowledge. But when SMS messages are freely sent to women all over, they know what to expect and they can be more proactive about their health. And this can help prevent child mortality. Other means or other ways ICT can help to reduce mortality in women by organizing PowerPoint presentations, you know, that are made available to communities. These presentations can be made in local languages. You can gather market women. I'm sure people are willing to make use of these opportunities in Nigeria, just that they are not easily accessible. If PowerPoint presentations are made, and these are presented to communities, maybe communities of local women, in the markets, for example, people, it's okay, I'll come and attend to that. Sorry about that. So through these means, people can have access to information and it can help them to know what to expect and what to do. And this will help to mitigate complications that would normally arise. And when it comes to child mortality, it's so sad that most of the causes of child mortality in Nigeria are also preventable. When I was in pediatrics, for instance, you will see children dying from diarrhea, you know, very simple things that just oral rehydration therapy could prevent. A lot of children die from diarrhea and it's extremely sad. If ICT is being made use of, and you know, these mothers receive messages from time to time that inform them of what to do when their children develop simple illnesses like diarrhea, it will help them to know what to do. They can go to the chemist, buy other rehydration solution, give it to their children. And this will help to prevent death from such simple causes. Even things like malaria. People think malaria is extremely simple and they treat it like it's such a trivial illness. And children die a lot from malaria. You see children coming in with very severe complications of malaria, like cerebral malaria. They bring them in unconscious. If people are provided with information about signs, early signs of complications in malaria, they can take things more seriously and they can present to doctors on time before it gets out of hand. So those are ways we can use ICT to prevent child mortality and even maternal mortality in Nigeria. For future, in the nearest future, we may begin to use telemedicine like it's being used in developed world. And I believe this will help a lot because people can have access to doctors even within their offices, within their rooms. Even market women can have access to doctors while they are still in the market. They don't have to close their stores in order to have access to doctors. But Nigeria of today, we know poverty is a big thing. Most people who die from these causes are even people who cannot afford to have internet or pay for telemedicine because it is not so cheap. Most of the companies that organize telemedicine don't do it free. You have to still pay for it. But in future, I believe telemedicine will have a big role in preventing maternal and child mortality in Nigeria.
Okay, wow. Thank you for the very practical message. And I love the way you put it, you had focused on the Nigerian situation. I'm sure you had a lot of experiences. Your residency in the UCH, in the pediatrics unit. You know, it's these things you talk about are so real. And I'm just trusting God for wisdom on how to go about this, because we see so much needless deaths. I live in a community, in a city, in the middle of a lot of villages. I mean, some of you, as I said, to get to Ibadan, where I am, is about 4 hours. To get to Ilorin is about 4 hours. And to get to, to get to Gomashot is about 4 hours. And also to get to outside the country, Benin Republic, is also around that time. So you can imagine the number of villages around where we stay in. And unfortunately, I don't think I can travel the way we used to travel. I don't think so. Because now the work I have to do within those, as I speak to you right now, I'm on duty. You know, I had to go for war rounds as early as 5:30. You know, so I instructed the staff that, look, by 7, I have an online meeting and I will not be free till 9 o'clock. But I'm imagining, and thank you for many of the proposals and solutions we have from Dr. Olajon. I can see Dr. Olajon is still around. Dr. Timitokwe, Omotayo, and you. I hope that we still have these conversations, because the problem with the Nigerian setting is that if you are not careful, you will believe that things are not possible because you are still living 30 years backward. I don't know how to explain this more practically than what I've said. And as I said, I can't say some things. I'm careful of opening up some things because some of the information I have, they are privileged information. Having worked in the administrative level at the primary healthcare center, secondary healthcare center, and now tertiary, you know, but I'm still open that we can work out something in telemedicine. Some of the villages we have access to where we have missionaries or key people there. I believe we can set some things up. You know, I don't know how we're going to work it out, but I believe we can set some things up so that we can even we can have maybe a representative there, because some of these communities don't even have a health worker. The best you have are people who are there on charity basis. maybe doing mission work and all that. So probably we can set up telemedicine or, mobile networks there to help those people. If we think about money, forget it. That's why running check is not easy. But for some of us, it's too late to look backwards. But we thank God we are getting more support. I mean, more than any time before. But we are also careful now because we are careful also of demanding for support because we don't want people to understand what we're doing.
So you arranged all those things. I collected the full folder. I think I tagged that one.
So I don't know. Because of time, we will not take because we like us to talk. So Dr. Owoye, we are grateful. We pray that God continues to bless you mightily in Jesus' name. We are recording this speech. We're going to be sharing it on our social media platforms at the right time. So finally, we're going to be hearing from an health educator from India. This is a man I respect so much. He has played a great role in helping us to improve our media in check. If you want to look at our social media platform, and without much introduction, because of our time, I want to welcome Mr. Shijuade Samuel. You're welcome, Mr. Shijuade. Thank you. The floor is yours. We have to finish. We have to speak in 10 to 12 minutes so that at least I have 1 or 2 minutes to round up. Thank you.
Sir, I will try and do justice to that. Thank you very much, Dr. Leye. I really appreciate what you're doing. Yeah, can you hear me? Am I audible? Okay.
Okay. Oh, sorry. Okay, I wasn't because of our time. I appreciated you, Dr. Owoye, and I moved on to the next speaker because we just have less than 10 minutes plus. You want to say something, ma? Dr. Owoye, you want to say something, ma? Okay, go ahead, Dr. Yeah. Go ahead, Mr.
Okay. Okay, am I audible?
Yes.
All right, thank you. Dr. Leia, I really want to say thank you for this opportunity to say a few things. And I also want to appreciate because I've been with you for a while and I can really say that you're a man of vision and that vision is very, very vital for the future of healthcare in Nigeria. Thank you for what you do at Check. Can I share my screen?
Yes, you can. Yes, you can share your screen. Yes, you can.
Oh, okay. Thank you so much. So, is my screen visible to everyone?
Yes, it is. Yes.
All right. Thank you very much. So I'll be speaking on leveraging on ICT to provide accredited education. As someone as UNESCO said, they said health education is an intervention in its own right. So health education is something that should be the core of our practice as health professionals. I mean, all health professionals. So it should be something at the very core of our practice. And C.S. Lewis said something. He said, says something. Every ship should know why it's out there in the first place. So as health professionals, why are we out there in the first place? We actually want to promote enhanced quality of life for populations, for every individuals that we come across. So that is the primary purpose of our profession. So health education, as UNESCO has said, is an intervention in its own right and it should be something at the very core of our practices as health professionals. So in today's talk, we'll be asking 4 questions. We'll be giving answers. I'll be giving answers to 4 questions. What are the goals of health education? Why is health education important? And who are those to provide health education? And how can we leverage on ICT to provide accurate health education? As the goals of health education are, number 1, to entrench health literacy. Imagine if everyone out there, the entire population is health literate. The truth is, they will be able to improve their health status. They will be able to enhance their quality of life. They will also be able to prevent premature death. They will also be able to take actions that prevent diseases. And at the same time, they won't have to, they won't have to have a financial crisis as a result of paying for health. when you take, just as the maxim says, the common maxim says, say, a stitch in time saves nine. So imagine if everyone is educated and they know the right actions to take at the right time, they're able to prevent a lot of problems for themselves. So the goal of health education is that of universal health coverage. Imagine if everyone is educated, we can as proper health education, the burden of disease, the burden of mortality will be greatly reduced. So we want to also look at the objectives of health education. The first objective is to enhance informed decision. When people are enlightened, they're able to make the right decision and at the right time, not just presenting cases late to the hospitals, to medical practitioners when things are worsened. They're able to make they're able to make enhanced informed decision and also make it at the right time. Then it can also help them to chart the course of action, the course of health action. They know what to, once they see certain signs, they know what action to take, they know where to go to, they know who to speak to. So another objective is to influence positive behavioral change. When people are well informed and they know that certain actions will lead to certain consequences, they're able to they are able to tilt more towards safety. So that is the objective of health education. Just as I said earlier in the words of C.S. Lewis, a ship must know why it's out there in the first place. And when we know the purpose of health education, then we're able to actually exert ourselves as practitioners to give out health education. Then we also want to, why health educators? Health educators are trained professionals working with groups in community settings or with individuals to help them understand how to live a healthy lifestyle. As long as you're a trained health professional, whether you're a dentist, whether you're a doctor, of course, some of us had our training primarily in health education. And you should be able to communicate. And that's one thing I think it's not, it has quite been lacking among health professionals, ability to communicate science. Of course, health professionals comes with medical jargons and they're unable to break it down to their population. That has been a disadvantage over time. So ability to communicate science. There was a video that was released not quite long and he was a comedian. He said scientists will come and say A plus A is equal to this and this, and people are not interested. But a comedian who will come, who knows nothing about anything, will say some rubbish and people will laugh and people will take that person as an authority. So communication is key as an health educator, as a health practitioner. We must add the component of communication to our profession. It's very important, and I hope we would improve ourselves. I know many of us already have experience, and for budding health professionals, those that are still in training, it's one thing that we must incorporate into our profession as we get our training. So we want to look at the need for ICT in health education. ICT is something that is becoming very important by the day. When we look at the fact that the human resources that we have is not enough to take care of the population that we already have and that we'll be expecting in the nearest future. Just 2 weeks ago, I think is it just 1 week ago now that the world hit 8 billion people, and WHO estimated that by 2030 there will be 10 million. There will be shortfall of 10 million health workers. Another person made an estimation by 2035 there will be a 12.9 million shortfall. So this is going to create a lot of gap. I could remember recently a friend of mine with a doctor was posted on his WhatsApp. He said, "Be careful! Don't make sure you don't get sick during this period because of brain drain. Doctors are leaving Nigeria and things like that." So we sometimes these are variables. Health is something that we can literally control by taking measured action. Just for instance, I've been in India for over 1 year now. I've not had any reason to take a drug to this doctor, not because I couldn't afford it, but I was very conscious, very deliberate about the actions I take, about the food I eat, about time to sleep and everything, because I'm well informed. I'm not saying that I could not afford it, maybe due to unforeseen circumstances. Of course, it could have happened. But the point I'm trying to make out here is that when people are well informed, they're able to take appropriate action. So But the truth is, many people out there are not well informed. So we need ICT to disseminate health knowledge to them, to disseminate health knowledge to them. So that's one of the reasons we need ICT. Then another reason we need ICT is to bridge, to bridge the gap of ignorance. And we see many medical practitioners here, surgeons and other medical practitioners would attest to the fact that when many people present themselves to the health facility, even when pregnant women in delivery present themselves, things are almost going out of hand. But sometimes it begs for the question, is it the problem of ignorance or the problem of access? So with ICT, we can bridge the gap of ignorance. We can also bridge the gap of access. So these are two things that ICT can help us to do. With proper health education, we can bridge the gap of access, we can also bridge the gap of ignorance. Then we want to look at areas of health education where ICT will prove very, very, very important. Human biology, like sex education, our young ones are growing. Sexually transmitted infection is one of the leading cause of death in Nigeria. I think I'm very sure of that. I don't think I'm getting my statistics wrong. And the young population are disproportionately affected. So how can we provide health education to them so that they can take appropriate decision? Then nutrition. Malnutrition is one of the problem in child mortality. So with proper health education, we can teach mothers on how to apply local knowledge of local foods to be able to bridge the gap of nutrition in childcare. Then hygiene. ICT will also prove very, very important. Then in family health, Dr. Busayo has already spoken so much about it. Imagine when a friend of mine just implemented a program on male maternal care, how males are meant to be involved in maternal care. When they are educated about certain signs their wife present, they're able to help their wives. When women themselves are educated about certain red flags, they're able to take appropriate decision. Then it's also very important in disease prevention. Also very important in disease prevention. Imagine when you know that certain food will lead to certain things, you're able to do away with certain things, certain behavioral dangerous behaviors that would lead to negative health outcome. Then in mental health, there are many online clinics now that provide mental health service to people. That's one of the areas where ICT is very, very important. Then in safety education, I could remember when I was doing accident prevention and safety back then in UI as one of my courses. I could remember how my lecturer used, he used videos that show certain action can lead to certain action and things like that. So ICT is very important in safety education. Then in use of healthcare. In the use of healthcare, people might be ignorant on what even the healthcare facility in the environment is really meant for. They might be ignorant. They might be ignorant in the services they offer. So ICT will also help bridge this gap. Advertisement, it's something different to create a system. Another thing is usage of the system. So we need ICT through all platforms. We can educate people on the use of the resources that are available within their environment. Then approaches of ICT in health education. How can we health educate? I think I'm behind shade. I'm getting behind time already. I'm going to listen up. Approaches of ICT in education. You can take the approach of lectures, demonstration. This can be in different form in different settings. Then symposiums, through seminars, conferences, and the last one is. Sorry, I didn't get the last one. There's something covering my screen. Skits and role play. We must be able to speak the language of this generation. The fact is, hello, is someone, Dr. Lee, I think I have your voice.
You have 1 minute more. This session is almost ended. Can you just round up, please? Sorry.
Okay, then we have the role. We must be able to speak the language of this generation. That's one of the things. That's one of the things where role play and skits comes in. So let me quickly rush to then tools in health education. We are health management apps. Just as you're seeing, I'm going to make the slide available there. Mass media here we can see Dr. Leye, health educating on a particular TV. Then we also have the example of social media. Someone like Akoko Doctor is speaking the language of this generation, the language of the Gen Z and the language of the Alpha generation. And people are actually learning a lot through this platform. So we also have teleconferencing. It's of course, former speakers have spoken about this. So I'm not going to speak much about this. It's also very important in human resource in the training of human resource. Then that leads me to my last slide here. The use of ICT in delivering health education is an opportunity to improve on national and global health indices. And as health professionals, we must seize that opportunity, because if we don't seize it, people that don't know anything, just like we've seen from media out there saying rubbish, and during Ebola, they told people to take salt. During COVID, they told people to take salt, and it was leading to negative health outcome. Then we must do it right. We must do it the right way, and we must do it very well. Thank you very much. Thank you for listening.
Wow. So much for just 2 hours. Thank you for recording these sessions, and thank you for the slide. We'll be sending it to all the participants. Once you send a message to us on our email, we're going to respond to you. Let us have your full name. That's all participants, as you're going to appear as a certificate of participation, and that will be awesome. Then most importantly, if you want to become a check member, please also let us know through your email, and we'll let you have the details on how to be involved in being a check member. We are not interested in the crowd. We are interested in serious people only. Thank you all for coming. God bless you all. In Jesus' name, have a blessed day. Bye, everyone. Thank you to all our speakers. We are grateful. We're grateful. We're grateful. Okay. Thank you, everyone. Thank you, everyone. Thank you, everyone. No, on this one. Please check family, not on this one. Look on it, please. My closings. Possible. You start time. Possible to understand.